Should be live on Facebook now, and there we are. Okie doke. It is the 12 o'clock hour on the dot here on the East Coast of the States. So let's start the show. Let's not keep the people waiting. Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this week, this month, and every month, now that we're doing them monthly. I'm a filmmaker and a writer. I've been working with CCF for about 12 years now, creating all kinds of video content, live video series like the one you're going to watch today, patient-centric documentaries, treatment-based videos, conference videos, thousands of videos probably over that span of time, but all with one mission in mind, and that is to spread awareness and education about neuroendocrine tumors. That's what we're here to do. Now, the value of the show you're going to watch today is really twofold as I see it. One, the information you're going to get from our guest presenter, and two, the community, the shared experiences and the shared stories from the community, the overall net community, which is incredibly strong and supportive, as well as the community here within Lunch with the Experts in the comment sections that you'll see. So you may see people already doing that, chiming in, saying hello, telling us where they're signing on from across the world. We'd love to see that. I encourage you to do the same thing. If you are new to this community, welcome. But lean into this community, embrace them. I assure you they will embrace you back, and that's extremely helpful. Before we get started, we always want to thank our presenting sponsor, Ipsen Biopharmaceuticals. We couldn't do this show without them. But we always have this disclaimer from them as well at the top of the program, and that is that the opinions expressed by the guest presenters, as well as the questions asked by the audience at home, haven't been created or suggested ahead of time by the sponsors of Lunch with the Experts. And CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation. Audience members should not rely solely on the opinions or information expressed by the guest and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. Okay, so that's a lot of words, as disclaimers often are, but really that last line is the main takeaway. We don't know your specific case, so we're going to give you hopefully some good answers to your question and general advice. And we wish for you to take that general advice and those answers back to your home team, which does know your specific case, and make the best plan and path forward for you. So today my guest is Dr. Charles Nutting, who was here almost to the date 3 years ago in September 2020, just as this show was getting started. So we're very excited to have him back. Dr. Nutting, it's good to see you again. Welcome to the show.
Thanks, Rain. I appreciate you and CCF asking me to speak again. And as I look at the comments on the side, it's amazing the reach.
Isn't it?
You know, it's literally around the world.
I know it surprises me every time, and we have a lot of people who are here every episode, but then we always have new people from Kenya and India and Ireland and just all over the world, and that makes us very happy here. Now, for those that might not have attended in September 2020 or may not know what you do, tell me a little bit about like where you work, what you do, and as I say, the role that you fill in this neuroendocrine tumor community.
Yeah, thanks. So I'm an interventional radiologist practicing in Denver, Colorado. I've been an interventional radiologist for 25 years, primarily hospital-based. We recently moved into the office-based lab, which allows us to do some of these procedures outside of the hospital in medically appropriate patients. I work with Dr. Eric Liu and Al Cohn at the Neuroendocrine Institute, so we work collaboratively. If they have patients that have liver-dominant disease who could benefit from a liver-directed therapy, then I will get involved in the treatment of those patients. And with neuroendocrine disease, we know that we're really trying to play the long game, and that we want to stabilize the liver as much as possible to provide, healthy long-term survival. As well as decrease symptoms and maybe get rid of some of those bulk-related symptoms that can be either some pain or abdominal fullness, as well as carcinoid-type symptoms with the flushing, diarrhea, and other things that go along with that. So I'm really part of a collaborative team, and I would say I'm an expert in liver-directed therapy, but I really rely on Dr. Liu and Dr. Cohn to help steer the appropriate patients to me.
Dr. Eric Liu, that name sounds familiar. I'm not sure if I've ever heard of him though, and people in the audience might have heard of him. He's been on the show a couple of times, folks. I've worked with Dr. Liu for about that whole time I've been with CCF. I first met him about 10 years ago, and so we love Dr. Liu around here. But I appreciate you making that distinction. But you did say about 40-50% of your patients are net patients.
Yes, I would
What we're
say
talking,
that from a liver-directed therapy standpoint,
right?
there's different therapies that we offer these patients, but of those patients, probably 40 to 50% of the patients that I treat are neuroendocrine patients.
Got you, got you. Okay, folks, so that's going to be the best way for you to get the best information today is asking specific questions about Dr. Nutting's specialty, really honing in on liver-directed therapies today. Just a couple of, best practices to help get your questions answered. Inevitably we get so many we can't get to them, and we try to, but that's kind of what keeps the show going is we come back. And if we don't get to your question, I encourage you to follow up with us at carcinoid.org or reach out to our new partner LACNets with the support line that they are able to provide, and we will get you the answer to those questions if we can. But while you're here, there is no limit to how many questions you can ask. I ask that you ask them in kind of generic little chunks, not too case specific. Again, we don't know your specific case, and that's a really hard question to field in this format. But we want to try to get you further down the road. That's our goal here. So if I don't see your question, there's a lot of them coming in. There might be a variety of reasons. Feel free to ask it again. Now, Dr. Nutting, let's lay a little bit of groundwork. As you probably well know, the net community is very well educated. So you'll probably get some toughies today, some tough questions. But I always like to consider the person who might have gotten diagnosed last week and they don't know what a net is. It's a new word for them. They're scared. They're confused. I always want to make sure that we lay some foundation for them. May sound simple to some people, but it may be very helpful for some people that might not feel comfortable asking these questions. So I will be the one to kind of lean in and ask the simple ones first. First of all, let's just start with the basics. What exactly is interventional radiology?
So interventional radiology, that's funny because my mom still doesn't know what I really do.
Neither does mine.
I'm, I'm a plumber pretty much on the inside, and I would say that interventional radiology is using minimally invasive techniques
Okay.
with some kind of imaging guidance
Uh-huh.
to perform a specific therapy. So most all of the things that we do are through very tiny incisions or just a needle puncture. Most of them can be performed on an outpatient basis, um, and which leads to a quicker recovery than some of the traditional surgeries.
Got it. Got it. Okay. So, next step. What are some of the typical therapies? I'm sure there are plenty that a net patient might experience.
Sure. So from my standpoint, most of the work that I'm doing is within the liver. And
Right.
we know that with neuroendocrine patients that the primary tumor very rarely ever starts in the liver, but it can start in the pancreas, the small bowel, the lung, and then tends to metastasize to the liver. The liver is an organ that can regenerate,
Mhm.
and it's something that you need to be able to survive. So most of our efforts are focused at trying to keep any liver tumors small. Some people, and if they can undergo a surgery, that's a very reasonable alternative to go in and kind of debulk or take some of these tumors out. But there are some patients that either aren't great candidates to have a major surgery like that, or there may be surgically inaccessible areas that are better treated from my specialty, interventional radiology. So the things that I do, if there's very small tumors and they're easy to get to, we can put a tiny needle in under ultrasound or CAT scan guidance, and we can heat up the tissue at the tip of that needle. That's called microwave ablation or radio frequency ablation. There's different energy sources that we can put through that needle to burn up the tumor at the tip of the needle. So we don't have to do a big incision to get down there. We can use X-ray guidance to help us with that. Once there's more than a couple of tumors, and unfortunately, this is typically the pattern that we see in neuroendocrine patients. If there's tumors spread throughout the liver, or if there's kind of bigger tumors that are hard to get to surgically, Then we'll start talking about liver-directed therapy using embolization. And so an angiogram is where we put a tiny needle into the artery and inject some dye so that we can see the blood vessels supplying the liver and the tumors. Embolization means that we're putting some kind of particle in the blood flow to block that off.
Mm.
And there's bland embolization, where we just use particles that help decrease the blood supply to the tumor. There's chemoembolization, where we can mix these particles with chemotherapy. And then there's radioembolization, where the particle actually contains radioactivities such as yttrium-90. The unique aspect of the liver is there's really a dual blood supply. So most of the metastases occur in the liver from the venous drainage that drain into the portal vein from the gut and pancreas and up into the liver. And that's where those tumor cells can get seeded and start to grow. The nice thing about this is they actually derive up to 100% of their blood supply from the hepatic artery. So you have this dual blood supply to the liver from the portal vein, which is venous, and the artery, which is supplying oxygenated blood. These tumors get the vast majority of their blood supply from the artery. So we use the artery as a highway to get into the liver and the tumors and deliver these therapies.
Got it. Thank you very much. That was thorough. I love it. As I expected, we already have lots of good questions rolling in, so I'm going to go ahead and pivot to that if that's all right with you.
Of course.
So, first one comes from Gwendolyn. Hello, Gwendolyn. What info about a patient's prior radioembolizations could be useful in making a decision about PRRT? And what constitutes a good response from radioembolization?
Yeah, that's a great question. So, what constitutes a good response from radioembolization? I would say that it's very rare to see tumors shrink up and go away. Complete response from most of these therapies is actually less than 5%. So, typically, what we see is tumors will stabilize, or if we're doing imaging that contrast is given through the IV, whether it's a CAT scan or an MRI, there's less contrast that's identified in the tumor, so there's less blood supply. So not all tumors just shrink up. Some of them lose their blood supply and can stay about the same size, but they may have the vast majority of the tissue in there being dead. We don't really do imaging at 1 month after these procedures anymore, at least radioembolization. We really wait about 3 months to 6 months to see. It takes a while for the tumors to shrink. They actually swell up in the short term because there's some edema or swelling that occurs from the treatment. So usually at 3 months to 6 months, we have a pretty good idea of how the tumor is responding. And that can be shrinkage, that can be lack of blood supply to the tumor. So those are two good predictors. Also, gallium scans can be helpful at looking at response to therapy. When we talk about PRRT and Y90, I think that first of all, there's been a couple of studies looking at PRRT in patients that have undergone Y90 and vice versa. It is safe to treat patients with both of these therapies. What you do need to realize is that radiation is cumulative over your lifetime. So your body kind of remembers how much it's seen. And anytime we treat patients with Y90 that have had PRRT, we look at the dosing of PRRT, how many rounds have they got, how many millicuries were administered. Typically, the uptake in the liver is about 1% of the total PRRT dose, so it's relatively low. But we do need to know how much PRRT has been given over what time frame and realize that this is additive. If the patient had received significant PRRT, then we may lower the dose of yttrium-90 that we're going to be giving for that particular patient. And that's something that I would talk to our radiation oncologist about, our physicist, as well as our medical oncologist at the Neuroendocrine Institute.
Got it. Thank you. Thanks for your question, Gwen. Next question comes from Jim. Jim says, I have over 20 cystic nets in my liver. I've been on lanreotide for about 3 years. Currently, there's a lot of conversation about moving to PRRT. I have significant progression over the past 4 years, but less change since starting lanreotide. Once you go to PRRT, the question is, does lanreotide need to stop? Is there a benefit in waiting to progress to that next treatment option to keep it in the toolbox? There's no net specialist in his area, so he feels a little hesitant to just jump to PRRT.
Where does he live, Rain?
Jim, let us know that if you're still in the call. I'm assuming that you are, and then it'll probably take a moment so we can either move on,
Sure.
Dr. Nutting,
Yeah.
or
Nope.
answer
I think
halfway.
we can answer that. And again,
Okay.
I would say that being an interventional radiologist, I'm not a PRRT expert. However, we do treat lots of patients who have undergone PRRT. And PRRT is reliant on the receptor of the tumor to uptake the PRRT and get good binding.
Mhm.
So these patients will have had some kind of nuclear study to make sure that they have receptors. When he says cystic nets, I'm curious as to his receptor status on those tumors.
Mhm.
You do now, again, I'm not an expert in this, but I would say that you need to come off of octreotide, lanreotide to open up those receptors prior to receiving PRRT.
Mm.
So that's important. You do need to come off of that.
Yeah.
If
Is
it's a liver, sorry, Rain, go ahead.
he just chimed in? Apologies to cut you off. He's in Vancouver, by the way.
Okay. So you may have a better bead on neuroendocrine specialists in that area. But, nowadays with Zoom, it's pretty easy to get a consultation, anywhere in the world with a net expert
Sure.
who can look at your images and render opinions. If you're talking about 20 cystic lesions in the liver, and it's a liver dominant disease, then that may be appropriate for liver directed therapy. So when we look at PRRT, if it's a liver dominant issue, in our practice, I would say that we tend to use liver directed therapy because I can get a therapy right on top of those tumors in the liver. More commonly, there tends to be disease outside of the liver as well. And PRRT is great because it's given systemically through a vein. It's looking for those receptors anywhere in the body and can give you tumor stabilization in the liver as well as extrahepatic disease.
Got it. Thanks for your question, Jim. Hopefully that helps. Moving on. Terry says, "Hi, Dr. Nutting. I have two liver lesions that have grown over the years. It has not been diagnosed since it has not been biopsied. The doctors have said it's not worth the possible spread. What do you think, or what might you do in this situation or next?"
So, and Rain, was that they have grown in size or they're stable?
They have grown over the years.
Yeah. So I think the rapidity of growth is something that I would look at. If things are relatively stable, there is a risk to biopsy. A biopsy is not a benign procedure. They're very safe, and I would say that a true complication from a biopsy is far less than 10%. One thing that we do think about is tract seeding, which means you have to put a needle through the skin into the tumor to get a piece of tissue. Sometimes tumor cells can come back along that track and cause tumors either in the skin or somewhere anywhere between the tumor and the skin itself. Um, if they're growing rapidly, I mean, if they're doubling every couple of months, I would say that probably deserves a biopsy. If it's a slow growth that has occurred over time, probably does not need to be biopsied. But it may mean that you could benefit from either microwave ablation if they're less than 3 centimeters in size, or consider even just a bland embolization, which is just the particles going into those two specific areas. And Rain, what I would say that's happened in our specialty over the years is that we become much more sniper-like in treating these tumors. So in the old days, we would just treat big swaths of tissue of the liver.
Mhm.
Now we're really focusing in with the technology that we have in imaging, with the AI guidance, with the robotic assistance, we can get very specific. So in this example, I would go into those two specific tumors doing an angiogram, And I would give the therapy right into these areas and then preserve the rest of the liver tissue, which is really a change, I would say, over the last 5 years.
Yeah, yeah, I've been hearing about that quite a bit. Thank you. Next question comes from Christina. Christina says, I have a primary in the ileum with mets to the liver, too many to count. I've had two TACE procedures, and in 3 weeks, and in 3 weeks I'll have one more to get the two larger remaining tumors seen on the MRI and the PET gallium. How many times can a person do a TACE procedure, or should we be looking at other alternatives? And feel free to discuss exactly what that is.
Yeah, so
Transarterial.
TACE. So again, TACE falls into that embolization category where we're doing an angiogram and we're finding the blood vessels that supply the tumor, and we're putting an embolic or some kind of material in there. With TACE, that stands for transarterial chemoembolization, and there's different types of chemotherapy that can be mixed with this slurry that's injected into the liver. The thought is that by injecting the chemotherapy along with an embolic agent, what we're doing is slowing down the blood flow into the tumor. The tumor will be treated, it will become ischemic because there's a lack of blood supply. And then the chemotherapy will have a longer dwell time, or kind of sit in that portion of the liver because it's not draining out. The arteries have been blocked off. Um, so how many times could you have a TACE? You can have it as long as your liver is tolerating it and as long as the arteries are open or patent. Anytime we put something in the artery, there's a small chance that it can block off. In general, we use these arteries as a highway to deliver the therapy. So we don't want to really block off the highway. We want to keep it open so that we can treat in the future. When you talk about miliary disease, so miliary disease are multiple small tumors spread throughout the liver.
Mhm.
And I think that's an important distinction from a miliary pattern to kind of larger tumors that are situated inside of the liver. We take advantage of this increased blood supply to the tumors to give the higher therapy load to the tumors, but to pull it away from the normal liver tissue. When we talk about multiple small tumors, they're really situated in normal areas of liver, but they're very close together. So some of these therapies, like radioembolization, may not be great in a miliary pattern because it's going to radiate the tumor, but it also radiates a little bit of liver around each tumor. So if you have multiple small tumors, the liver is going to get, a higher dose of radiation than if you had a couple of large tumors that really pull these therapies in. So chemoembolization, again, we're playing the long game. You're going to hopefully live a long time with this disease. So I would defer to your interventional radiologist as to, it sounds like they're doing the correct thing. Usually you don't treat the whole liver with TACE at one time. You stage it and you treat one side and then you treat the other. And again, you wait until you have some follow-up imaging. 3 months, 6 months, you can follow tumor markers, you can do follow-up imaging. And if things are responding, then you probably stand down and just kind of let you heal up and have a good quality of life. And then as if tumor markers were to go back up, or we saw something on imaging that maybe one of the tumors is starting to grow, then we go back in and treat that specific area. So I would say people can have numerous TACE procedures.
Okay.
It's really dictated by liver function studies. And one of the most important predictors of how much liver health you have is your total bilirubin. It's called T-bili, and it is something that we look at when we're going to treat somebody's liver to make sure that they have enough hepatic reserve, that they have enough normal liver tissue to be able to tolerate these procedures and recover well.
Got it. Thank you. And appreciate your question, Christina. Next question is coming from Jody. Jody says, I'll be having two bland liver embolizations 4 weeks apart. Anything I should do to help prepare for these procedures? And what's the recovery like?
Yeah, so that's a great question. And so bland embolizations, they hurt. You need to know that they hurt. And you just need to be prepared for that going in. It always helps if you stay hydrated. And I think going into procedures, if you go into a procedure relatively healthy, well hydrated, feeling okay, you tend to come out of it better. But the idea behind a bland embolization, and can you ask her if she's going to be on everolimus as well?
Yeah, Jody, let us know down in the comments if you are,
Um,
and let's just give her a second.
So the idea behind how does a bland embolization work? Well,
Mhm.
you're putting particles in the artery that are starving the tumors of their blood supply. Um, and anytime you starve something of its blood supply, it hurts. So usually what we see in bland embolizations, and it tends to be, I would say, within an hour or two after the procedure, and it tends to last. It's less than a week. It's usually a couple of days, but you will have some nausea, you will
Mhm.
have some pain, and you can have a low grade fever. A low grade fever doesn't mean that you're infected. It just means that that's your body's natural response to kind of dying tissue.
Mhm.
Um, Go ahead, Ray.
Yeah, I did hear from Jody in regards to everolimus or everolimus. She actually said that I don't know what is that, so that's a good opportunity for us to talk about that. And then she added, I get monthly octreotide injections, but that's not stopping growth. So
Yeah.
everolimus.
Just getting back to um, the bland embolization. Um, you tend to do it in segments. So just like you said, you're going to treat one side first, then the other side, usually 30 days later. Um, just I would say stay hydrated. We tend to give some medications um, for the recovery. A Medrol dose pack tends to be um, a good uh, a good therapy to decrease liver swelling. It can help you with some nausea and improve your appetite. Um, the other medication is usually a narcotic of some sort, and that's to help you with the pain. And I would encourage you, if you're hurting, you should take that. Um, we we tend not to give antibiotics, although that's not always true. It depends if you've had any surgery on your biliary tree, and I would say that most interventional radiologists do tend to give you um, some amount of antibiotics, and it's usually just short term, and it's to help prevent any kind of um, infection that could occur. So those are kind of the three medications. Stay hydrated. Just be
Mhm.
prepared. You're going to hurt for a couple of days to a week, um, but you will recover. And and my best wishes to you. You kind of get beat up though. You're going to get beat up for a week, and then you're going to recover, and then they're going to beat you up. Another month later,
Yeah.
um,
Yeah.
and
Yeah.
you will recover from it.
Folks, if you just joined us or joined us a little bit late, this is Luncheon with the Experts, a Carcinoid Cancer Foundation program. We're here today with Dr. Charles Nutting, an interventional radiologist, talking about all things liver directed therapy. I wanted to say that Margaret says, I just love this show. It gives me so much hope when I'm feeling down. Margaret, I love to hear that. And that's exactly what we are hoping to do, to give you some information and also hope. Hope is a big part of it. I also want to give a special shout out to our friend Pat, who sent us a message and said that she lost her husband to this fight in August, which we hate to hear. And she's a big supporter of the show and attendee, and we're just sending you all our love. This is a tough journey, but we all try to support each other through these times. So, all my love, Pat. Appreciate you being here. Next question comes from Judy. Judy says, okay, I have SI net metastasize to the liver. I have a few, if any, symptoms. I've gotten lanreotide shots once per month since my diagnosis 15 months ago, and I asked my oncologist about liver directed therapy, and he said no. The side effects would be too significant. How bad are they? What are your thoughts on that, Dr. Nutting?
That just goes to show the variability of patients and physicians in the community. Um, I don't disagree. You don't have to treat every liver tumor. If you're asymptomatic, meaning you're not having neuroendocrine type symptoms from a functioning tumor. Um, and the tumor is not pushing liver tissue out of the way to cause pain. And it's stable. You don't necessarily need liver directed therapy. Now, I think you have to look at liver function studies to make sure that your liver is tolerating what's going on inside of it. And if they start to grow, then I think either surgery to do a debulking, and that's what Dr. Liu and other neuroendocrine surgeons specialize in. The interesting thing about surgery for neuroendocrine liver disease is, unlike other cancers, these things are very well encapsulated. They tend, and Dr. Liu describes it as just kind of like popping out a golf ball. They're very well contained. Many cancers tend to be diffusely infiltrative, where you have to take out a big piece of tissue. Dr. Liu's explanation of this to me, and he loves to show pictures, is that you can kind of pop these things out of the liver, and you don't have to take a large swath of tissue. So debulking, whether it's surgical or done with a catheter, um, I think that you have to look at the entire patient. You need to be part of a multidisciplinary team. I'm encouraged that she's asking questions such as, am I a candidate for this? Um, and my guess is that if the tumors were to grow or you were having symptoms, then that may be a therapy that's considered. If these are sandostatin positive tumor with receptor, PRRT may be an alternate as well. And remember, we're playing the long game. So it's, how do you sequence your cards? You may see several different therapies in your lifetime. The question is, which ones do you receive first that don't jeopardize future therapies?
Got it. Thank you. From Samantha, I've had 3 bland embolizations and ended with 8 agonizing days of no bowel movement. Any suggestions on how to avoid something like this for future procedures?
Yeah. So I would say that the embolization itself, and you're right. I mean, I always feel bad for patients that have that kind of recovery. The bland embolization per se would not cause the constipation, would be my guess. It tends to be the narcotics that are administered either during the procedure or the recovery. So as we know, narcotics can cause pretty severe constipation. Things that you could help to get around that, or at least mitigate it a little bit. I would say hydration is good. Stool softeners can be very helpful, as well as either fiber or Metamucil, something to help that your bowel movements move along. And you could start that, I would say, a couple of days prior to the procedure, and carry it through until probably you stop the narcotic therapy. So a week or two after the procedure, but that's usually helpful. You can't really mitigate all the pain, the nausea, and some of the low grade fevers, but you can help some of these secondary side effects like constipation.
Got it. Got it. Appreciate your question, Samantha. Next question from Steven. What is the best surveillance scheme for early detection of liver carcinoid metastasis? Or how long should surveillance continue after the primary and local lymph metastasis has been removed?
Yeah, that's a good question. I don't know that I'm the best person to answer that, but most patients are getting gallium scanning at some point. The good thing about a gallium scan is that it looks at the entire body. So unlike a liver CAT scan, you're pretty much looking at the liver. Abdominal CAT scan, you can see some things outside of the liver as well, but some of these functional scans, like a dotatate scan, would be helpful to look at extrahepatic disease outside of the liver, as well as the liver disease itself. My guess is you're probably getting some form of imaging every 6 months to a year, as well as maybe following tumor markers. And if tumor markers acutely rise, then it may prompt a sooner imaging study.
Got it. Thank you. From Sarah, what causes liver swelling and pain? I have this occasionally and find it hard to treat. Currently on Afinitor and octreotide.
So liver swelling and pain, I would say that that's multifactorial. There are many things that can cause that. Uh, Sometimes we see patients, and I see this on follow-up MRIs and CAT scans of patients that we've treated. Tumors can actually, as they start to die, they can have a little bit of bleeding inside of the tumor that then enlarges the tumor fairly acutely inside of the liver. And we definitely have patients that complain of pain related to that. I'm not saying that every time you have liver pain, the tumor is growing or has been bled into. But there's a lot of hemodynamics and there's a lot of stuff going on in that tumor environment that can cause intermittent swelling. So I don't have a great specific answer, but it's not uncommon. And if it's persistent or severe pain, I think imaging is a reasonable, follow up with your doc, get some imaging and see what's going on in that specific area.
Got it. Got it. From Lisa, Lisa says, I have unknown primary with metastases to the liver. I've had one bland embolization in the past 5 years, and the radiologist doesn't want to do a second because of the location of the biggest tumor in segment 8 of the liver. After first embolization, I was miserable. I had to be put back in the hospital for 3 days because of pain. It took 6 weeks to finally have pain totally subside. And the tumor is slowly growing. She's on monthly shots of sandostatin, and the tumor is also causing issues, she says. What, if any, other treatment can be done? At the last count, there was 28 tumors.
Okay. So when we talk about 28 tumors and a segment 8 lesion, um, I'm surprised that she's just had one bland embolization. To be honest, it sounded like she didn't have a very good recovery. This is very kind of typical of the patients that I see with Dr. Liu. And when we talk about segment 8 tumor, there's 8 segments inside of the liver. About half of them are left-sided, half of them are right-sided.
Mm-hmm.
And it's determined by the specific artery, portal vein, and biliary drainage to that area. Segment 8, segment 8 is up underneath the diaphragm. So it's an area that's very hard to get to surgically.
Okay.
In a patient like Lisa, Dr. Liu and I would typically treat that larger tumor in segment 8 with radioembolization. So radioembolization tends to be better tolerated than a bland embolization, meaning patients don't get it sick. It's done outpatient. They go home the same day. Radioembolization does require a mapping angiogram, so kind of a dry run reconnaissance of that area. We give a test dose of medicine to make sure the beads are going to go where we want them to. We may block off an artery that goes outside of the liver to make sure that when we give the high dose therapy radioactive beads, it goes up into the tumor and nowhere else. I think especially since Lisa didn't have a very good experience with bland embolization, and the segment 8 tumor is the one that tends to be getting larger, I would do a Y90. I think that's actually a great indication for radioembolization of the segment 8 tumor, because that's the area that's growing. I think she tolerated better than a bland embolization. And then I think you have to reevaluate. You probably get a mapping angiogram, a treatment angiogram with the Y90, and then you get some follow-up imaging about 3 to 6 months after that. See how the segment 8 tumor is responding, as well as the stability of disease within the rest of the liver. Unfortunately, you may need a bland embolization in these other segments of the liver. And so we tend to reserve Y90 for bigger tumors that are causing problems. And then we would do a bland embolization to the rest of the liver over time.
Got it. Thank you for that so much, Dr. Nutting. Thank you, Lisa, as well. Folks, we've got about 20 minutes left here with Dr. Nutting, so we're going to try to get to as many of your questions as possible. Keep them coming. Good questions today. Dr. Nutting, Could you tell me a little bit about what we were talking about before we started the show today about the changes in outpatient care when with the liver directed therapies instead of having to be necessarily in a hospital setting, et cetera?
Sure. So one of the things that's been happening with interventional radiology is more and more of these procedures are being moved to we call it an office-based lab. It's really just a clinic setting inside of our interventional radiology practice. It tends to be outside of the hospital. It can be freestanding or in a medical office building. And we have invested in our radiology equipment rivals that of the hospital. So from a patient standpoint, these procedures can be delivered safely and effectively in a setting outside of the hospital.
Mhm.
And there may be some benefits to that. Patients, sometimes it's hard just to park your car, get into radiology to have your procedure done. Most of these office-based labs have parking outside. It's a quicker preparation time for a procedure. Uh, the nurses tend to follow the patient from the time they get into the clinic through the procedure to recovery. There's several papers being published showing that procedure times are quicker, delays are much less, patient satisfaction is higher because it's a smaller footprint. It's easier for patients to kind of get in and out. Now, I still have hospital privileges, and I probably treat about 10% of my patients at the hospital, but the vast majority can be treated in an office-based lab. Um, Patients who have labile neuroendocrine disease, we would treat those patients in the hospital. If we thought they were going to have significant pain during recovery, we treat those patients in the hospital and allow them to undergo a 23-hour observation with recovery in the hospital. But I could tell you that most of our patients are very happy with the current setting in an office-based lab and can get in and out quicker and go back home to recover.
I imagine. And we were also talking before we started recording today about how there haven't been a ton of developments necessarily in liver directed therapy, and just in the past few years. Is that fair to say? I don't want to claim
I
that
would,
much.
yeah, Rain, I would say that's accurate. I
Okay,
think
okay,
that, the therapies that we have are kind of the therapies that we've
yeah,
had over the last 10 years.
gotcha. Okay, so my question is, if you could write the script, right? What are the areas that you'd love to see progress, maybe in the next 5 years?
Yeah. I think, targeted therapies,
Hmm.
I love the idea of PRT and PRT alpha,
Yeah.
that these things can circulate throughout the body and seek out tumors. It would be nice if we had something similar to that in the liver, if we could deliver something in the liver that not just based on flow, but based on tumor, um, the surface tumor antigens that allow these therapies to be taken up by the tumors. If we could deliver some of these through the artery and have them accumulate in the tumor based on flow, but also based on tumor characteristics, I think that would be a home run. That hasn't proven out to date, though.
Got it. Got it.
And they did a study. I think it was in Germany where they did PRRT delivered through the hepatic artery for patients who had liver dominant tumors, and there wasn't significant improvement in outcomes whether that was delivered intravenously or delivered through the hepatic artery. So, you know, there are definitely advantages to having something delivered through the vein. It's going to go throughout the entire body. It's not a procedure. It's really just a needle stick, and much more easy to do. So, I think that current therapies are good. It'd be nice if we had a little bit more targeted that we could deliver through the liver.
Got it. Got it. Um, how does the interventional radiologist treat carcinoid or net symptoms during the procedures?
Yeah, and that's something that I always, whenever I have a neuroendocrine patient, you need to know whether it's a functional tumor or not. Meaning,
Right.
is a patient coming in with symptoms? Is that what we're trying to control?
Right.
And there's a there's different hormones and proteins that can be secreted. Some patients have, um, insulinoma where it drives down the sugar levels. So it's really specific to that patient's tumor. We use octreotide or sandostatin given intravenously during the procedure. We tend to use about 100 micrograms given right before the procedure. If we have somebody that we know is labile, meaning their blood pressure can go up and down, they are very symptomatic, we'll mix 500 micrograms of sandostatin and 500 cc's of fluid, and that'll be infused at 100 cc's an hour. And we can, if the symptoms, the nice thing about sandostatin is that if symptoms occur, we can give sandostatin to control that. And really, you can't give too much sandostatin. Dr. Lou has always told me, if somebody's symptomatic, just keep giving them sandostatin until the symptoms start to resolve. Mm-hmm. So it's a very safe medication. When we're working in the liver, we are going to, I would say, make those tumors angry. As we starve them of their blood supply, they start to get stimulated and secrete some of these proteins and hormones. So by giving octreotide, we're kind of stopping that mechanism. We're binding up the receptor sites, and it's very, it's very successful. It's uncommon to see a patient progress through sandostatin.
Got it. Thank you. Do bland embolizations damage healthy liver tissue?
So that's a good question. And I think that the answer is there's probably a bit of transient damage to normal liver tissue. And that's seen by, if you were to draw some laboratory values, we'd see that the transaminases and other enzymes in the liver can go up temporarily, but then they tend to come back down to normal.
Okay.
So we rely on the vascularity of the tumor to kind of pull the beads away from the normal liver tissue. Now, as an interventional radiologist, when I embolize something, when I put these particles in the blood supply, the idea is not to shut down every blood vessel in the liver. Mm-hmm. We call it pruning the tree. So mm-hmm. if you think about branches on a tree, they get smaller and smaller as they go out. The tumors tend to be at the very leaves, at the very kind of distal part of the tree as these vessels get smaller and smaller. So when we put particles in the arteries, what we're trying to do is prune the tree. We want to kind of knock out some of these very small vessels at the periphery, but we want to preserve the structures that are larger. And I think by doing that, you preserve as much normal liver tissue as you can, but are still treating the tumors.
Got it. Thank you. That question came from Gwendolyn. Thank you, Gwendolyn. With all the different options, therapies, how do you make the decision of which one to use? I'm sure it's a big answer, but
yeah. So some of the things that we've talked about, like miliary disease, to me, miliary disease is multiple tiny tumors spread throughout the liver. Mm-hmm. In my mind, that's not a very good candidate for a radioembolization. Mm-hmm. So using yttrium with Cersphere or Therasphere, because multiple small tumors aren't going to take advantage of accumulating the radioactive material in the tumors without radiating the rest of the liver tissue. Mm-hmm. So, and that's because there's multiple small tumors and there's going to be a little bit of liver tissue that gets radiated around each tumor. So with the radioactive beads, we tend to treat kind of larger tumors. And again, we're going into the tumor. We're not treating that whole portion of the liver. We're trying to be much more sniper-like than we are kind of a shotgun approach. With bland embolization, there's probably less damage to normal liver tissue than there is with radioactive embolization. And I would say that TACE or chemoembolization falls into kind of that same bland embolization category. The liver recovers very well from those therapies. There is a therapy that we haven't talked about, which is called drug-eluting bead. And so a drug-eluting bead it's an embolic bead, so a little tiny bead that soaks in chemotherapy and then is injected into the liver. And again, the thought is that as this bead is stuck in the tumor, it's slowly eluting chemotherapy or letting it dissolve out into the tumor. Um, Dr. Sulin has uh, a trial. It's called the RETNet trial. And it was looking at these different embolotherapies for patients with neuroendocrine disease. And what they found in their early interim analysis is that the drug eluting bead therapy had a higher complication rate. There were some biomas, there were some breakdown of bile ducts that occurred. I can't remember, I think there may have been an infection. So most interventional radiologists who are treating neuroendocrine disease don't really use these drug eluting beads. We use bland embolization, we use chemoembolization, and we use radioembolization. The other thing that we should bring up is that some of these papers that have looked at radioembolization 4 or 5 years out show that there may be some um, cirrhosis-like features of the liver called radiation-induced liver disease.
Mm.
And in my practice, I use radioactive beads fairly sparingly. And again, we want to use them in areas that have a tumor that's going to take up most of the radiation dose. We don't want to just spray radioembolization throughout both sides of the liver, because I think in a small percentage of patients, it's probably 5%, they can develop some of these where the liver starts to kind of scar down and create some fluid in the abdomen. So I think we're much more conscious of who we treat with what, and we're looking again to play the long game. And sometimes patients may have a very aggressive tumor and they do need radioactive beads in both sides of the liver, but that's a much different scenario than somebody who's kind of had these tumors that are chugging along for a long period of time, where bland embolization or chemoembolization may be more appropriate.
What's the current, this may be under debate, what's the current approach, or maybe what's your perspective on sequencing when it comes to interventional radiology?
So sequencing, I would say, is again, looking at the patient in a multidisciplinary setting,
Sure.
determining if it's liver dominant disease or if it's primarily extrahepatic. If it's liver dominant disease, and there may be a couple lymph nodes in the abdomen, that's still considered liver dominant if the tumors are primarily within the liver.
Mhm.
We would use probably bland embolization as a first approach, because and we would treat the most diseased side of the liver first. Uh, you know, if we just look at percentages of the liver, 70% of the liver is right-sided, just based on liver anatomy. 30% is left-sided. If the tumors are spread throughout both sides of the liver, we would tend to treat right side first with a bland embolization, let the patient recover for about 4 to 6 weeks, and then treat the left side with bland embolization, and then get some follow-up imaging in 3 to 6 months.
Okay.
If someone were to progress through the bland embolization, then we would either consider chemoembolization if it's a miliary, multiple small tumors, or radioembolization if there are some larger tumors that need to be treated. So that's kind of the way that Dr. Liu has educated me, and that's how we treat most of our patients. And again, every patient's individual. We may
Totally.
switch that up depending on the tumor type or symptoms that we see.
Yeah, 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 absolutely. Michael chimed in and said, just finished my second Y90 radio embolization. Fingers crossed. Ours are crossed with you, Michael. Dr. Nutting, maybe my last question here. Um, what do people, what are some common misconceptions people have about interventional radiology that you'd like to address, if anything? What do people get wrong about it?
Well, I think that some people, and probably not patients, maybe more physicians, think that we're just technicians. That we're here to kind of just fix a problem, and realize that we've gone to medical school, we've done extensive training, we've done fellowships. So this is 12 years of training. We are an integral part of a multidisciplinary approach to treating patients. Um, I'm fortunate throughout my career to have worked with great surgeons, medical oncologists who believe that we're all part of a team. And I think that, I talk to Dr. Liu more than I talk to most of my partners in my practice. So it is this constant collaboration that gives, I think, patients the best, number one, experience, but number two is the outcomes. And it's understanding what card to play in what order so that we don't burn any bridges and that we can treat the patients in a stepwise fashion that is going to lead to improved quality of life as well as survival.
Hmm. Love that. Love that. Appreciate you taking that question. Steven says, thank you for this deep dive into liver therapy. Absolutely. Ruby says, excellent show today. Love it. Thanks, Rain, Dr. Nutting, and CCF. And for those that asked some other questions that weren't necessarily in the vein that we were discussing today of liver directed therapy, still, I encourage you, you don't have to wait till the next show next month to get your questions across. I know this is very important to you. So, again, I'll reiterate, reach out to us at carcinoid.org or our partner LACNet's support line at lacnets.org/support line. We've put that link in the comments section so that you can reach that. Dr. Nutting, thank you so much. The people are very grateful as well. They're saying so in the comments. I appreciate your time and you being with us again.
Thank you very much, Rain. I appreciate you and CCF as well as all the patients.
Absolutely. Lorraine says, thanks for a great show. Zebra Strong. I could not agree more. And thanks to you all at home as well. We can't have this show without you, right? This is why we're here to serve you. Remember, you can always reach out to us if you have follow-up questions at any time. Special announcement, we have a new documentary coming out at the beginning of next month. It might be out before our next show in October, so stay tuned for that. This is an exciting one. Thanks again to our presenting sponsor, Ipsen Biopharmaceuticals. We couldn't do the show without their support. And finally, my name is Rain Bennett. I have been your host, and I appreciate you watching. Please join us next time on Luncheon with the Experts. Stay healthy, stay safe.